We are good. Okay. All right. So let's talk about the gait cycle. This is last week's presentation. So, and everybody can see my screen. So we're looking at the stance phase as a whole. Does anybody remember what percentage of the entire gait cycle is spent in stance phase?
60.
60. So it's about a 60-40 split. Can anybody think of a instance where a patient would spend even more time in stance phase than swing phase in total? Any distinctive, maybe not a diagnosis, but just a observation of that patient that would end up with that result?
Would it have something to do with dorsiflexion or plantar flexion?
It very much could. What if they had excessive dorsiflexion or plantar flexion weakness? And so when their tibias roll over their ankle in that ankle rocker, they just, their feet don't come off the ground as quickly as we do. Because, you know, when we push off on our toes, you know, our feet rise up off the ground naturally in terminal stance. So if they're spending a bunch of time dorsiflex as they go through stance phase, then they will spend an extended amount of time in stance phase. What about people that are just walking more slowly? They're probably going to take much shorter steps and spend a little bit more time in stance phase than swing phase. Okay, so then our first stance phase of gait, or really our first gait cycle, is initial contact. So this is a quick action where the foot contacts with the floor. So this is where we have the onset of weight transfer. And which of the three rockers is occurring here?
Heel.
The heel rocker. So, and the heel rocker, can anybody describe what is occurring at the heel rocker for me? What's happening at the foot and the ankle?
Weight acceptance?
Well, what happens at the ankle when the weight comes onto the heel? We start in dorsiflexion and we plantar flex a little bit, right? So that's kind of the heel rocker as the foot lowers to the ground. But the weight acceptance here and shock absorption is occurring at loading response, right? So loading response is it takes up more time of the gait cycle, about 10%, and this is also where we have the shock absorption. So if loading response is impaired, that patient might experience some issues with that weight-bearing stability that we're looking for. So your early stance phase is very important for the patient to have a sense of stability. If they have issues with ankle range of motion or knee stability, they might experience loss of stability in this stage here, as well as mid-stance as well. So mid-stance is while the tibia is progressing over the stationary foot. It takes up a little less than 20% of the gait cycle. And in addition to the lower limb having to maintain stability, the trunk also has to maintain its own stability as well. And what do we refer to the trunk and the arms and the head as when we're talking about the body? Sorry, I overspoke.
Pedestrian?
Or no? Yeah.
Pedestrian, no, it's actually the passenger, because remember, pedestrians don't take the train. They walk alongside and jump on the train, but they don't have the tickets. They're vagabonds. So this is where the mid-stance rocker is occurring, which we called we called it the mid-foot rocker in earlier slides. So mid-stance and mid-foot are synonymous in this case.
Can I ask a question with that as well?
Sure.
There's one anatomy structure that actually does a dual role in both the passenger as well as the mobility. Do you guys know which which anatomy structure that is that does both?
Can you guys hear
you guys
Dr.
hear
R
me?
okay?
Yeah.
Okay. They're just thinking.
What was the question again?
Okay, so there
Come on
is
in.
a, well, I'm gonna be wearing a mask because we're
It's okay.
close, but I'll take it off after. There is a structure of the anatomy that it's a dual role for both the passenger part as well as the mobility. Do you guys know which anatomy structure that is?
I would guess arms if I had to,
Okay. Anybody else?
because of swing,
Right. Okay, that's a good one.
balance.
I don't know what, I'm thinking it has something to do
Pelvic?
with the hip.
Yep, it's close to that vicinity. What
Just
axis
throwing it out.
though? What axis?
The vertebrae, the vertebral column.
It's close to that. Okay.
Pelvis.
Bam, right there, pelvis. Pelvis acts as a dual role. It helps stabilizes the lumbar upper portion, and then it helps with mobility of the lower extremities. That was a good one.
I like how we worked through that there.
Yeah, that was very good.
Okay, so let's see, mid stance all good, guys. We're working on progression and stability here. Then we have terminal stance. So terminal stance begins with the heel rise, and it's basically working all through until the opposite limb is making contact with the ground. So terminal stance and initial contact are kind of two, you know, they're kind of happening opposite one another in the gait cycle between the two limbs. And we're progressing beyond the supporting foot. So now the tibia is inclined anteriorly. And again, we're still, since we're during most of that cycle until the very end, we're still in single limb support. Stability is still one of the main goals of this phase. And then pre-swing, the opposite foot's already on the ground. So we're basically just the very final stage. It's only about 12%. We're just getting ready for the stance phase limb to toe off. This is where we have our final rocker, which it's referred to as the terminal rocker here, but what's another name for the final rocker?
Forefoot rocker?
Yes, correct. So the forefoot rocker, that's where the metatarsals are contacting and then rolling over. We have metatarsal extension, and we are toeing off and getting ready for swing. So that's basically, I mean, pre-swing and initial contact are kind of opposing one another too, because one is the foot making contact with the ground, and the pre-swing is the foot just about to leave contact with the ground. And then we're going to talk, now that we've gone over kind of the phases, just in brief, we're going to discuss the muscles of the foot and ankle. So we start from the bottom up, and then we're going to discuss kind of what's happening in the foot and ankle at each of these stages. So I think, well, we got to go through, I guess we can go through swing phase, even though, you know, it's the lesser phase, it's only 40%, but initial swing, the foot rises up off the ground, the tibia is inclined very much anteriorly, and it's kind of bringing the foot from behind the stance phase limb forward until the foot crosses in front of that vertical tibia that we see in mid-swing. So mid-swing, the limb has crossed in front of, and it's advancing in front of the stance phase limb. And this is when foot clearance is kind of the most important function of this phase of gait, because without foot clearance, we tend to have falls or near falls. And that's a gait cycle that we commonly have to pay attention to for orthotic patients and sometimes prosthetic patients as well. So when I say near falls, I don't know if I brought that up last week, but what do you think a near fall is? It's basically when the patient doesn't actually face plant on the ground, but maybe their toe catches and they still stabilize themselves at the last minute. So it's basically a near miss or a near fall. It's almost as bad as a fall itself, but it's, you know, it's still something that should be documented, because if you want to treat people that are experiencing near falls just as much as you want to treat the actual people that are falling, because as soon as they start, as soon as they have that first fall, then they've already lost confidence in themselves, and not to mention there could be a very costly hospital stay resulting from a full-blown fall. So if your patient comes in and is trying to downplay the fact that, yeah, he's not fallen, but he's caught him or herself several times, well, you don't want to just brush that under the rug. You certainly want to find out what's causing these near falls and treat them just as much as you would a face plant or a severe fall. And then finally, we've got toe clearance. The limb has advanced forward. The knee is extended. The foot is dorsiflexed, ready for what phase following terminal swing?
Stance.
What?
Double
Stance.
limb support.
Did you say double limb support?
Yeah.
Yeah, but what's the
Initial contact.
Yes, bingo. So all of which are true in one way or another, but initial contact is what I was looking for, because that's the first part of stance phase. So this terminal swing rounds out the swing phase, rounds out the gait cycle, and it's basically the pre-swing, or let's say terminal swing is to swing phase as pre-swing is to stance phase, because we're preparing for the very next phase of gait. I hope that analogy makes sense. It's been a while since I've, isn't that a, yeah, anyways, I'm not gonna, I digress. Okay, so that's our review. Does anybody have questions on the phases of gait before we move on to, we start to dial it in a little bit? Okie dokie. So let me get to the next. I'm gonna just pause this sharing and then we will get to the next one. So I am going to, let me do something really quick. So Dr. R and I are gonna spend this afternoon doing something really cool. We are going to replace all of the videos that are unfortunately not working. So we're gonna add videos to this PowerPoint. We're gonna take the videos today and I'll probably have them added early next week so that you can refer to those. But for today, I'm about to put up a new PowerPoint. I've just removed those video files so that we're not distracted by the fact that they don't work. So let me put that on right now. And there we go. I'm gonna put it at the very top so you guys can go ahead and pull that up. It's gonna be called Foot Ankle Normal Kinematics, No Videos. And then I'll replace the one that has the videos later. I'm really looking forward to when we can do the gait mat. But we're just gonna hit a bunch of anatomy stuff in the meantime, and then we'll pick right back up where we left off. Come on.
Emily, do you want to talk about the registration for that?
Yeah,
okay.
Sure. While we're kind of out of PowerPoint or whatever, we're going to be using what's called visible body. And I'm going to show it to you guys, an example. Let me see. Let me go back to sharing. So have you guys used visible body in Dr. O's class yet?
Mm-hmm.
Okay. So we're just going to refer to it. We're going to give you deliver the content as we normally would, and then kind of, since we aren't in person and we don't have those awesome models to look at anymore, we're going to use this to visually discuss things like origins and insertions and actions, and look at all the muscles and how they relate to the surrounding muscles. So you've all registered for it then, I assume. So if I send you an invite, you can easily accept it and get, okay, great. That's what I was looking for, some head nods. We're not going to do that just yet. We're going to do the content first, and then I'm going to assign a few pages, probably from the lower limb lab, for you to work on and complete for next week, more than likely, to be determined. So let's go back to, here we go, starting from the top. And let me switch the views.
Okay.
Okay, perfect. All right, so you can progress with this, just these is
Okay.
fine. You don't have to touch anything over there.
Okay.
And you can swing around here if you're ready. You got this.
All right.
Okay. All right, so I'm gonna let Dr. R take over, and I'm gonna be right here. So if anything comes up that I wanna share about what she's discussing, and specifically orthotics and prosthetics, I'll be jumping right in. But I'm gonna let you take it away from here. Guys, ask questions, please. I don't want you to feel like I wanna feel like it's in person, okay? So as much as we can't be in the same room as one another, you can ask questions as if we are, even though I'm not staring into your souls necessarily this whole time. So take it away.
I guess I'll take this off then.
Yep, and I'll keep mine on over here.
Good morning, guys. I think this is more nerve-wracking, actually,
I can
on a
I can
video
totally
versus
relate.
live. So did you guys have a good week so far? It must be like a Monday.
Yeah, I know. I think it feels like a Monday.
Okay. All right. So we're going to talk about the kinematics of the foot and ankle complex. There is a question I'm going to revert to for the gait cycle. There is actually one part of the cycle where our feet actually don't touch the ground. Do you guys know what activity that could be? Where your ankle actually doesn't touch the ground.
Running.
Exactly. There's a phase called float phase, and that means your feet are actually not touching the ground, and that occurs in running. Exactly. All right. That was just a fun tidbit. So we'll get right into, okay, so we know the structures of the foot. I'm going to further explain about the muscle as well as the structures of the foot, because it's important to know what bones are involved as well as what muscles involved. The more you get experience with learning what's considered a normal gait, the better you can pick up on what's considered abnormal. So you should have a better understanding for it. You guys probably already went through some of the anatomy with Dr. O, but it's always good to repeat and apply it together.
Real quick, did you guys you started with the hip though, right?
Have you guys done what areas of the anatomy have you guys touched base on?
Basically started on the surface anatomy of posterior, anterior thigh. Then we went down into the posterior and anterior of the lower leg. And then we started touching on the foot.
Okay.
Okay.
So
So
that's
then
pretty good.
it's about the same, yeah. So, well, whatever new things that you learned, you can impress Dr. O in the next one. Just don't tell her you learned it from us. She'll be impressed. So we'll start with that as well. So first, the structures of the foot, we're going to look at the functional segments as well as the muscles, like I said. And then we're going to look at each area of the gait cycle where what occurs. So we know there are 26 bones, including 2 sesamoids, 14 phalanges, 5 metatarsals, 7 tarsals, and 33 joints. So there's more joints than bones. I'm not going to put it on the next slide yet. So I'm just going to ask you, what bones make up what we consider the hind foot?
Tarsal and calcaneus.
Right. And that's mostly our subtalar joint. Okay. And then what bones make up the mid-tarsal joints?
Cuboid, the navicular, and the cuneiforms.
Right. And then the last one, what makes up the forefoot?
Metatarsals and the phalanges.
Right. Okay, so that we discussed the segments, the hindfoot with the calcaneus and the talus, the cuboid, the navicular cuneiforms, and then our forefoot. Okay, so we're going to talk about the muscles. I am going to have us kind of go through what I call OINES, which is our origin, insertion, nerve, and action. It is good to know that because then you're aware of when you see an abnormal gait, you know what muscles may be affected, including a nerve. And I'll tell you really quick, when I was an outpatient, the doctor just gave me an order. I just had the basics, height, weight, age, and all I had was something called peroneal nerve palsy. That's it. So by me knowing what the peroneals are going to be, I'm going to know what's going to be affected. I'm going to know whether it's going to be, depending on which peroneals, dorsiflexion and plantar flexion may be affected, as well as knowing the eversion is going to be affected. So that's always good to know that as well. So we'll start with the plantar flexors. Other than the gastrocs, can you guys name me other plantar flexors? And this can include eversion as well. Do you guys need some strong coffee? You guys can use your books, just
Soleus, Achilles tendon.
our soleus, yes.
The fibularis muscles, or the longus and the brevis, or
Oh.
peroneus.
Yes. And then there's 3 more.
Tibialis posterior.
And then there's the flexor digitorum longus and the flexor hallucis longus. Okay, that plantar flexor group has inverters and everters in there as well. So it's a combination. Now we have the dorsiflexing group. Okay, what muscles are involved with the dorsiflexors?
Tibialis anterior.
Yep.
Extensor digitorum longus. And the hallucis longus.
There you go. Okay. And then there's one more, and that's part of the peroneus muscles.
The tertius.
There you go. Very, very good. All right. So let's go with the origin, insertion, and nerve for these actions. We know the actions already. So for the gastrocs, do you guys can use your books. Where does it originate at?
Why don't you explain how it crosses 2 joints?
Okay, so it's going to be at the condyles of the tibia, and it inserts. Do you guys know where it inserts at?
Achilles tendon.
Achilles.
It's a calcaneus epithelium. Yeah, yep. And then what nerve is involved with that?
I'm sorry, I'm a little confused. Are we talking about the gastrocnemius right now?
Yes, we're talking.
Sorry
Yes,
about that. I was a little all over the place.
no, that's okay. I'm just kind of breaking it down a little bit. I know you guys probably may have already discussed this with Dr. O. I just feel like it's important to know as well. And by us repeating it, it actually helps you learn, and then you can be able to apply it when we get right into the gait cycle.
To be completely honest, we really haven't discussed insertion and origin that deeply.
No.
Okay, then I won't get into it deeply. We'll just go through the basics.
Started like learning where they are, like
Okay.
2 days ago. I'm not saying that that's an excuse for why we don't know it, but just we haven't really discussed that yet.
Okay, well, I'm not going to get into too much detail then, and we're just going to briefly go overview with it.
Okay.
For letting me know that, because then Dr. O will get more into it with you guys. Okay, so then let's go ahead and go to the inverted groups. So we have the inverter groups made up of the soleus, as well as the flexor digitorum longus, flexor hallucis longus, extensor hallucis longus, and tibialis anterior and posterior. Really quick, there is something known as the triceps surae. Do you guys know what that is, or have you heard of that?
Is that the soleus and the gastrocs coming together, and they're the
Yes. That's
There that.
Yes, that's exactly correct, Michael. So it's going to be the soleus and the gastrocs. They're the huge plantar flexor group. Out of those muscles, which one's the largest plantar flexor?
Gastroc.
Actually, I thought so too, but it's actually the soleus. The soleus is the most largest and more powerful of the plantar flexors. And it's more powerful as well when you have it in knee flexion at 90. That's just extra information for that. So now that's your inverted group. How about your everted groups? Okay. There's the peroneus longus, the peroneus brevis, peroneus tertius, gastroc, the medial head, and then we have the extensor digitorum longus. Okay. This is just a quick question and a quick thing I'm going to throw out there. Out of those muscles, there are 2 that actually dorsiflex out of that everted group. Do you guys know which one it is?
Peroneus tertius.
Yep. And one more. The extensor digitorum longus as well. So the extensor digitorum longus and the peroneus tertius dorsiflex and evert. And then the other ones, peroneus longus, brevis, gastrocs, are all plantar flexors and they evert. Any questions there?
I just have a quick one on gastrocnemius.
Sure.
Just looking at it, there's 2 heads. Is that a medial and a lateral head?
Correct. Correct.
And then they merge distally to then form into Achilles tendon, calcaneal tendon.
Mm-hmm. Yeah, they all merge into the Achilles tendon, inserting in the calcaneus. Okay, so I'm going to kind of give you guys a little information on the side here. There is there's another anatomy structure that you guys may be familiar with. You may have heard it. It's called the plantar fascia. Have you guys heard of what that is? Or have you ever heard of it? Like plantar fasciitis is one diagnosis that you may come across. Oh, Tracy, I've seen you nod your head, so you're aware of it. Okay, so what that is, plantar fascia is a fibrous connective tissue that connects from the calcaneus to the metatarsals. That helps a lot with shock absorption. It helps stabilize the mid-tarsal joints, especially when we're doing running or climbing. That comes into place with that. What it does is it helps with loading response by the fascia moving away from the toes. So it's more of a tight, what I would say a tight rod kind of like. So what that does, it allows shock absorption to occur when you're taking a step. And then after it loads, when it's unloading, it relaxes passively. So that means that the calcaneus and the tarsal heads will come back together. So it's more loose.
Like during swing?
What's that?
Like during swing, it's loose and then preparing to tighten again on initial contact loading response.
Right, exactly. And that's what helps with that. A lot of times, do you guys treat plantar fasciitis?
Oh, yeah.
Okay. So
Yeah.
you
guys will hear a lot about plantar fasciitis because where it inserts on kind of the anterior calcaneus, or where it originates rather, is sometimes inflamed, which can happen when a patient's foot and ankle is constantly in a state of plantar flexion, such as like when we're sleeping, our toes point down because we can't actively keep them up and have the sweet dreams, beauty sleep that we love and know so well. So what happens when that patient stretches that foot and ankle, that plantar fascia, when they go into dorsiflexion on their first several steps in the morning, this is very often seen in the early morning and then kind of will decrease throughout the day, but it's basically pulling and tugging on the anterior calcaneus and causing then inflammation, and sometimes it'll even like slightly fracture the bone a little bit. So what we try to do is maintain the length, the looseness of that tendon, maintain the length by dorsiflexing the foot throughout the sleeping hours. So we basically will put the patient in night splints while they're sleeping so that that tendon doesn't have the opportunity to shorten during the 8 or 6 or 5 or 4 hours that we sleep. And then that way the patient isn't going through that stretching as soon as they wake up in the morning. So, you know, most of us that don't experience plantar fasciitis, we have no issues, but it can affect anybody. It can affect an otherwise healthy individual. It can happen very, what's the word, like just for an interim period, just randomly. It can go away as randomly as it appears. It can be debilitating, or it can be just, you know, mild plantar fasciitis. So other treatments we can do are custom foot orthotics or off-the-shelf foot orthotics that will apply a little bit of pressure in the medial longitudinal arch to help maintain the length of the plantar fascia by pushing kind of up into it. And they also make these little straps that are partially elastic to push up anterior to the calcaneus. It'll relieve the pulling and just, you know, support that arch the same way that inserts would. So when I was at the VA, they did kind of a 3-part approach. They would do night splints for at nighttime, obviously. They would do foot orthotics in the shoes, and then they would do these little straps to support the arch. And they'd basically attack it from all angles, and it, you know, pretty good conservative results that wouldn't require things like steroid injections or I don't know if they use Botox for plantar fasciitis, but steroid injections are basically putting a Band-Aid on the real problem because it does nothing to prevent the shortening of the tendon. It just relieves the pain and inflammation. But for severe cases of plantar fasciitis, then they would potentially do steroid injections. So just a little tidbit from an orthotist.
Right. And as a physical therapist, we assess the structural parts. Most of the time it's stretching. We're teaching them how to do stretching, learn how to structure, because if they've got poor arches, that's going to contribute to that. There is correlation, but it's not really stated research-wise that bone spurs may also be associated with it, not necessarily causing it though. So that can also, as well as, like I said, poor support arm. So if they have poor support or poor shoes, there's no stability, that can also cause the inflammation of the fascia. A lot of runners, we do come across a lot of runners that do have this. And a lot of times we would do like an ice treatment, rest, pretty much rice, and then just ice, and then stretches and exercises along with it. So
have any of you, I'm sorry to interrupt, have any of you heard of RICE for a treatment of athletic injuries? It stands for rest, ice, elevation, and compression. Not in that order.
Not in that order, right? Compression and elevation.
So elevation obviously helps reduce the inflammation. So you want to elevate the body part over the heart at least. You don't have to have it all the way up in the air. And then compression. So little for the foot specifically, compression socks are good for athletes. And then sometimes the socks even apply specific pressures in the arch. So you can get them with or without that additional support. And then ice and rest. So activity modification, and then a couple times a day icing the feet. For specifically plantar fasciitis, I've seen and heard the recommendation of putting a frozen, taking a frozen water bottle and rolling it underneath the arch of your foot is a really simple way to quickly ice it down, and then, it'll stick it back in the freezer and it'll be ready for the next round.
Right. Okay. So, and then of course, that's where the longitudinal arch is also under there where the metatarsal head. And that also helps with loading response or loading absorption. Okay. Okay, so what we're looking at, it's a blank graph basically. We're going to be looking at the sagittal plane, so that we're looking at mostly the plantar flexion and dorsiflexion. So you see some numbers on the side. On the left are your degrees of motion, and then at the bottom is your percent of gait cycle. So what we do here is we split it in the center at 0 degrees, and then we separate it. Dorsiflexion is above 0 degrees and below is plantar flexion. And then we have vertical axis that we're going to put with the dotted dash or the dash lines, and that signifies what percentage of what gait cycle you're in. So for example, the first one would be like 0. This is looking at it. I may have some numbers off here, but 0 to 2 degrees, for instance. Yeah. Oh,
Yeah.
I'm just like if you're looking at the chart itself and you don't have the numbers, this is how you can look at it. So you can see like 0 to 2. 0 to 2 is the gait cycle, initial contact. Then you have the next percentage, which is 2 to 12 would be the loading response. And then 12 to about 32, and let me see, okay, 12 to 31 would be your mid stance, and then so on. So it separates all that into there. And then you can see from 0 to 60, that's gonna be our stance phase. Okay, so first thing we're gonna look at is the initial contact. So that's when the heel is striking the ground. Really quick, we have something called ground reaction forces. So for Newton's law, back in physics, for every action, there's an equal reaction. So when we put our foot down on the ground, we're having an equal reaction coming back from the forces from the ground. Ground reaction forces only occur during the stance phase of gait. Okay. There are no ground reaction forces for the swing phases.
Somebody living near the airport?
An airplane going by?
I think that was
Right,
me.
you, Jason.
I'm outside on my patio, and that was the little biplane flying towards the beach.
Oh, I wish. Oh, too bad. Okay, so that would show here. So there's a little red mark in there on the graph that you can see, and you can see like the dorsiflexion, what is going into the plantar flexion. Excuse me. So, okay, so this right here is an EMG. Now, the EMG is we're testing the electric myogram, basically the intensity and the timing of the muscular activity. For each area of the cycle, you can see what's working harder and what's passive. And we're going to break it down in each cycle and explain what muscles are more affected in what area. So we have the initial contact, and which what Miss Emily said, our heel rocker comes in place for here. So with that being said, it's 0 to 2% gait cycle. It's not very much. And we initiate the heel rocker as well as impacting deceleration. Okay, so for deceleration, we are actually focusing on the ankle plantar flexion with subtalar eversion. Okay, so when we went through the muscles, we kind of know what the plantar flexors are, we knew what eversions are and the everters are. Okay. For us to control the tibial or the tibial placement advancement, you're going to need the eccentric controls. And that's what's helping to gradually control that foot to have contact on the ground with the ground reaction forces. So with that being said, the eccentric control are going to be your tibialis anterior, your posterior, and your extensor hallucis longus and extensor digitorum longus.
So it's kind of counterintuitive. We're plantar flexing, but there's actually no plantar flexors, well, the tibialis posterior, but there's no, it's the lengthening of the dorsiflexors that are slowing down, decelerating the, basically the foot lowering to the ground. When we have issues with dorsiflexor weakness, like in many of the diagnoses we'll talk about, we'll often see a gait deviation, and we'll get into it more in depth, but it's called foot slap. So basically, due to dorsiflexor weaknesses, the patient cannot slowly lower their foot to the ground, and it ends up being a slapping motion at initial contact rather than a nice controlled lowering of the foot to the ground. So it's kind of counterintuitive. You think, oh, okay, I'm plantar flexing. The plantar flexors must be working. But if you look at the EMG, you're like, okay, the gastroc and the soleus are completely silent. So what's working? And it's all the dorsiflexor group, but it's happening eccentrically, which also there's no distinction on the EMG, whether it's eccentric or concentric. And just to be sure, do you all understand the differences between concentric muscle activity and eccentric muscle activity? Which is the traditional muscle shortening, pulling 2 points together and creating a shortened muscle length.
Concentric.
Right, and then eccentric is what we're talking about specifically here in initial contact. That's lengthening of the muscles, or just basically, they're working to slow it down. So if I might be correct, but is there more eccentric muscle activity than concentric muscle activity in the gait cycle? I don't know if it's by much.
Well,
but.
yeah, but depending on swing.
Okay.
When you get into swing, it's going to be more concentric to isometric actions. So yeah, regarding stance phase, it's going to be a lot of eccentric control for sure.
And then the last type of muscle activity, does anybody know the third muscle, I guess muscle activity is the best way to put it, that we haven't really mentioned a lot yet?
I just mentioned
She
it
just
too.
mentioned it, but it's isometric. And then iso means same. So the muscle is just staying the same length. It's neither lengthening nor shortening. So it's just holding strong. It's isometric.
So like if you do like exercising, when you're doing isometric, it's basically using your own body weight as part of the exercise regimen.
It's a wall squat.
Exactly. Yeah, exactly. And for us, like having patients that have knee replacements, we do a lot of quad sets, which are just having them push down and working on strengthening their quadriceps muscles. And that's just the basic stuff, but we have them do it. We have them do it for a certain amount of reps, have them hold it for a certain amount of seconds, and then release. And we build them up from isometric and up. Eccentric work is a lot more tougher, and you're going to be using a lot more oxygen consumption as well. Yeah, with that whole Krebs cycle stuff. So that's what it's important to know. What activities, eccentric, concentric, are going to be taxing for that patient, because it's how they're utilizing that oxygen that's getting converted to carbon dioxide, to ADP, to ATP, to glycolysis, into muscle energy. So it's important to know that that's what's affecting that as well. So, okay. So the next one, the loading response, is what we consider the foot flat. And we can see the degrees of motion, and it's coming down from plantar flexion up to dorsiflexion. So it is here that you can see what muscles are being used more often here. And as you can see, it's the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus, with the tibialis posterior and the soleus assisting there. Okay, so it's about 2 to 12% of your gait cycle. And this is where we're going to realign the angle of the ankle axis. Okay, and the motion again is ankle plantar flexion and subtalar eversion. Regarding plantar flexion, we're looking, that's going to be the sagittal plane we're looking at, and then we're looking the coronal, which is the eversion. So with that being said, that's the muscles that it's going to be activating for this group is the tibialis anterior, your hallucis longus, your extensor digitorum longus, your tibialis posterior, and your soleus and gastrocs are going to be what's activating during loading response. Okay.
So it's like the same 4 muscles as initial contact plus the 2.
Plus
major plantar flexors, or yeah,
Right.
now we have 3 plantar flexors and 3. So it's, they're
Split.
pretty balanced.
Yeah, it's pretty much balanced. And that's going to be what this is occurring as the eccentric control here of the soleus, the gastrocs, and then the plantar flexors to allow that. Loading response, this is where the most shock absorption occurs in the gait cycle. In preparation for mid stance. Also with the loading response, and I'll just give a quick thing about it. With the loading response as well, we're looking at how much the feet can absorb that energy and the ground reaction forces. So throwing it out there, what do you think is more involved with that? The pronators or the supinators? Is it more hindfoot valgus or varus? Any guesses?
Valgus?
Correct. That's what's absorbing the most shock, is you're going to be into the pronation, which allows it to be absorption of that calcaneal. Okay, Michael, I'm going to put you on the spot here. What are pronators? Like, what's affected? Like, is it calcaneal eversion or inversion?
It's calcaneal eversion.
Correct. And where is the tibia rotating, externally or laterally? I mean, internally or externally? Laterally or internal?
The tibia would be rotating internally. Externally?
It's a 50-50, you got it, yeah.
I was going to get it right one way or the other.
Yeah, exactly, okay. And with that as well, what happens at the ankle joint more? Is it more dorsiflexion or plantar flexion?
Closed chain.
Would it be
Yeah.
dorsiflexion?
This is gonna be close chain, so this is gonna be your foot on the ground.
So you're saying when you're standing and you're putting all your weight on the foot in the center of your foot,
Mhm.
you're pronating, so your foot would be more dorsiflexed?
Mhm.
Not dorsiflexion.
So the foot would be coming closer to the tibia, right?
It'd be actually,
So you
it would be the opposite way. It'd be plantar flexion. Because you're putting the loading response on, so you're doing more of the plantar flexors.
okay.
In the gait cycle.
In the gait cycle, yeah, correct.
Okay.
Okay, very good though. All right, so I'm gonna move on.
I have a question.
Sure.
That on the last slide, is the dark line the ground reaction force?
Yes. Oh, I didn't mention that. Yes, the ground reaction forces, and I have a really great diagram that I'm gonna put up next week that's gonna show where the ground reaction forces hit at what point of each joint. So, because it is a lot to remember, because it does hit different areas. So for the example here, this is the dark line as a ground reaction force that's occurring. So this is gonna show it's posterior to the ankle.
And depending on
Right here.
where the ground reaction force is in relation to the joint, specifically we're talking about the ankle, will affect the motion occurring at the joint. So for example, we're talking about loading response. We already know that the foot has a plantar flexion motion occurring. So then I know that because that's happening, and that's normally what does happen, that the ground reaction force is going to be posterior to the ankle joint. Versus if the ground reaction force for some gait deviations is anterior to the ankle joint, that's going to cause the motion of ankle dorsiflexion. So, and it all comes back to understanding how normal gait happens and occurs. You can kind of work backwards or forwards, however you want to look at it, to figure out, okay, so where's the ground reaction force if normal motion is doing XYZ at ABC joints? So I kind of, the better you understand the gait cycle, the easier I think it is to understand ground reaction forces, rather than working the opposite way and trying to remember where the forces are to then figure out what motions are occurring. And you may all learn a little differently, but I think if you get a good basis on what motions are occurring at which phases, then you can figure out where the ground reaction forces are going to be in relation to those individual joints. Because it's different for the ankle, knee, and hip, and we'll tie it all together.
Right.
It'll be lots of fun.
Yeah, that's always the fun part.
Yeah.
Yeah, but it's important first to kind of know the gait cycle and what normally happens, and then adding the ground reaction forces, what causes certain torque to occur.
I got
So,
a question.
what's that, Mike?
So the ground reaction force in initial contact would it be more posterior on the calcaneus?
Yes.
So it would be closer to the
Back,
the
like,
back.
slides.
Sorry, I'm confused.
Okay, let's go back through each slide. Yeah. Actually, it
I
would
didn't see
be-
ground reaction force in the last slide, and I'm
Okay.
just trying to put it
Okay.
together.
Yeah, no problem. We'll go back to the cycle. We'll kind of go through it each again.
Well,
Right here.
Show
well,
it.
It's actually
it's like-
going to be.
can I ask a question really quick?
Saw it too.
Oh,
While we're covering that, it might make sense to go over the arrows also.
well,
Maybe I missed you saying it, but I don't know what those are signifying either.
yeah, that's what I'm gonna explain a little bit further. Actually, this is gonna show where what's happening at the muscle group, but it's actually the ground reaction is actually anterior of it. So it's actually anterior of it. That's why decentric control of these muscles, the tibialis posterior, anterior, extensor hallucis.
Can you let me see? Because we can have.
So where you could point that out to us
Yeah.
on
Here.
the slide so we can sort of see what exactly you mean.
Okay.
Let's do a pen. I want to make it bigger.
Okay.
Emily makes really straight lines too. So
Oh my God! Not on the computer.
Does she? Okay. I
on
not
the
working with
chalkboard,
I guess. I wonder if I can. Yeah, we'll just do.
Oh,
chalkboard,
that's you.
bloody whiteboard.
So why don't we draw like anterior, so like right above here, like the
From contact here, though.
no, on the foot, like right here.
Okay.
That's gonna be your anterior, like
Is it anterior because that's where it bisects with the tip of the toes and the knee?
Look at that straight line.
That was incredible.
Whoopsie.
oh, okay, well, that's better than mine. So
Yeah, I don't have my slide rule.
I don't know how to use that, so I'm not gonna
Just
put-
Erase it and try it again.
try it again.
Eraser. Okay.
I believe in you.
All right. Where do you want me to put this bad boy? Same spot. The positioning was good. Just like from here to here, basically.
Well, with this part, how about can you draw like this and make an arrow coming down, so it's showing like it's the eccentric control planar flexion.
Mm-hmm.
So that's what that whole arrow I think is confusing.
I think it's just showing where the motion.
It's just showing the motion, yeah, but to show the ground reaction. Sorry, we're just talking about stuff. So the arrow is just showing the action of what's occurring, but okay, so maybe I could put a different color for that one.
Okay.
Okay.
Yeah, whatever.
Oh,
Okay. So
okay,
the
anyway.
motion
So this
in
is the
red.
motion right here. This is what's occurring. So it's showing it's planar flexing, eccentric control, planar flexion. Okay, and then the ground reaction force is going to be
Here's the ankle joint, by the way. It's technically the distal tip of the medial malleolus, but we're going to signify it with that blue mess
So
that I
then
just
the
created.
ground reaction be in front of the malleoli.
I can't even see
Can you
my
do
stupid
that?
cursor when it gets so small like this. We'll do.
I have a great diagram that
green.
once I can pull it up, it'll be easier to tie it in. Perfect.
Oh, come on. I can do it.
Okay, well, that's close enough.
Yeah.
That's pretty good. That's pretty good. So the green over there is the ground reaction forces going up. So it's anterior to the malleoli. And that's for that control, essentially controlling tibial placement forward. Any questions? Does that help answer your question, Adam?
Sorry, I got to move my cursor around to unmute me. Yeah, I understand. So the arrows in each of these slides will explain the motion of basically the foot and ankle joint, the overall ankle joint.
Correct.
Right. So in this one, it's saying like, okay, the motions at the ankle joint, the foot is plantar flexing slightly, but it's the next phase here where the foot actually makes contact down with the ground.
Right.
And maybe the line isn't appearing in the last slide because weight hasn't actually been really placed on weight acceptance hasn't really.
Well, it's such a short, quick motion
Right.
that I don't think they put that on there. But I will have that up there for you guys as well. So by looking at it, you'll have a better idea exactly what. And it's right now it's 10 o'clock. Should we take a little break?
Yeah, let's go ahead and do that. And also, Adam and all of you, the only thing that I know how to do well in Zoom, well, I didn't do it so well yesterday, but if you do keep your mics muted and then you want to just hit the space bar and hold it down, you can temporarily unmute yourself so you don't have to worry about moving your mouse and stuff like that. So obviously I didn't do it very well yesterday in our little meeting, but I do know that that will work pretty universally for all of you, in case you didn't know. So let's go ahead. Let's go ahead and break for
10 minutes.
let's do about 10 minutes, and then we'll start back up with we'll go over loading response again. Okay. All righty. Where is my mouse? There it is.
I don't know. And also, you know what we're gonna do?
Mm-hmm.
Why don't I draw this?
Michael, you're unmuted.
How's your weekend, or how's your week going, Tracy, so far? I can't hear you.
Are we waiting on me?
No, we still have a break. I just saw Tracy. Other people are still coming back. No. I was just asking how you guys' week is going. How's the week going so far?
I mean, it's going well.
That's good.
As good as it can be.
Yeah, right. This is the first time teaching online for me, so this is a new experience here.
Just saying, this is a new platform for me as well.
Oh, is it?
Well, I've had like phone calls on here and done like little things, but never had a class.
Yeah, same here. My meetings are usually on the video. We usually use what's called MS Teams. So Zoom we don't really use very much at the VA.
We still breaking? We
Yeah.
still on break?
Yeah.
Hey guys, we're coming back any minute now. A few of them are still look to be out. When it's white, it's
Was it white? Is
working.
that what it was?
Well, now it's good. Now you
Even Bubbles is back.
Bubbles. Bubbles is looking great in the face. Hey, Bubbles.
Yeah, she is. She's looking old. Aren't you, baby girl? Hey, Dad.
Oh God. I mean, I think I'm gonna have you do it because you do a better job at it. But it's gonna be posterior, so we're gonna redo it all.
Okay. All right.
We'll go over it all. I was just kidding.
All righty, guys. Okay, so can you guys see my screen okay? Good. We need to be recording. Okay, we're good. All right, so we're going to redraw the ground reaction forces to what we originally thought. They are posterior, which is causing a plantar flexion moment. So that's my makeshift ankle joint. It's normally the distal tip of the medial malleolus, but we're looking laterally, so it's going to be a little bit different. And then basically from, wow, I just hate how I can't see my mouse. It like disappears when I'm up there. All right, so from where the heel is contacting, it's just going to be ever so slightly posterior. and then that's creating a kind of the anterior movement of the tibia, or anterior rotation of the tibia, because our next phase of gait is going to be the foot lowering and the tibia rotating even slightly further anterior. So the ground reaction force remains posterior through loading response until the body weight, so the passenger unit, everything up here, starts to get further anterior. I know you guys love that. So because think of it, I'm trying to think of how I can picture it. Picture the ground reaction force is kind of like, is it a metronome that goes back and forth?
Mm-hmm.
So it's kind of like a metronome. It starts off leaning posteriorly, and then it transfers very much so anteriorly. And it does that over and over again through each stance phase. So remember, it's only occurring during stance phase, and you can pretty much relate it to the metronome.
Do we have everybody on?
Yeah, if you're not here, say I. Just kidding. Everybody probably just has their cameras off.
Okay.
Hey,
Yeah,
that's
there
what I
you
figured. Okay, so moving forward, loading response, it's still remaining posterior to the ankle joint. The foot is lowering to the ground, and then go back to the EMG or the chart here. So now we are moving into mid stance. So remember, everything above this bold line that's going all the way across is going to be dorsiflexion. So prior to mid stance, our ankle is in plantar flexion. And then as the tibia rolls over the foot, we now have a dorsiflexion angle, or dorsiflex position of the foot and ankle. So the muscles responsible, can you go back just one? The muscles responsible for this dorsiflexion are actually the plantar flexors. So now the anterior, the dorsiflexors are taking a break. They are no longer eccentrically working as they were previously. And now we see activity in the soleus and gastrocnemius, tibialis posterior, which is a plantar flexor and a everter, and then a couple of the other everters, the peroneus longus and the peroneus brevis. So this is what muscles are working during mid stance. And basically what's happening is the plantar flexors are working now that the foot is flat to move the tibia anteriorly and pass it over top of the ankle joint, basically. So now we have gone from a posterior ground reaction force to now an anterior ground reaction force, because we've gone from plantar flexion to now dorsiflexion. So if you can imagine, what's the passenger unit, what is it up to, at this stage, the gait in mid stance? It's basically going to be right above this big bold line. So we've gone from our body being, back here somewhere, and the ground reaction force was coming up at a posterior angle, to now the body is right on top of the locomotor unit. The ground reaction force has shifted anteriorly, and now it's basically straight up and down, or perpendicular to the surface. And then as the passenger unit moves forward, then we're going to start to see the ground reaction force shift even further anteriorly during the late stance phases of gait, terminal stance and pre-swing. So basically the mid stance is when everything switches from the ground reaction forces posterior to then anterior, and they remain anterior to the ankle until the next, basically through the end of stance phase until initial contact of the next step. So we already know that tibial progression is our main goal of stance phase, in addition to what? What else is happening in the lower extremity during stance phase of gait?
Shock absorption.
I'm sorry, I always talk over people right when they speak up.
Can you say that again?
Shock absorption.
That, yes, you have shock absorption specifically of the mid-tarsal joint. So we had shock absorption of mostly the hind foot in loading response, and now we have shock absorption in the mid-tarsal joints. Since that's basically where all of our body weight is, being borne onto is mid-tarsals. And it's also coincidentally where the ground reaction force is passing through the joints that the ground reaction force is passing through. So that's what's absorbing shock in mid stance. And then we also have to have basically just stability. This is where we start to see single stance dorsiflexion. And the muscles that are primarily acting are the plantar flexors. So the gastroc and the soleus are eccentrically working to dorsiflex the foot. And then a few of the other plantar flexors, the flexor digitorum longus, tibialis posterior. And then remind me again, what are the peroneus brevis and longus? What motion do they cause at the ankle? It's in the coronal plane. There's your hint.
Eversion.
Eversion. So those are located. You can kind of see where they would be located. They're going to be attaching kind of to the lateral lower leg, and they work to evert. And then there's these two are also the plantar flexors. So really, if we look at, I believe we go back a little bit to the EMG, you don't see any activity except for a little blip of the tibialis anterior. So it's all going to be eccentric muscle activity from the plantar flexors to slowly allow the tibia to rotate anteriorly.
The soleus being the main eccentric controller.
Right.
So, and then here also subtalar joint, it is actually going from pronate, it's going to neutral now. So at mid stance, the subtalar is at neutral.
And then one more, we're going, because now we're starting to see dorsiflexion, and we're going to continue to see it at the ankle through the rest of stance phase. There's one little tidbit about ankle stability. The ankle is most stable in the dorsiflex position. So we kind of, we're in single limb stance. We want that foot and ankle to be as stable as possible so that we don't collapse. And so naturally, the patient or the foot and ankle is going to want to go into a dorsiflex position to maintain that nice stability. So here we have a little arc of continued dorsiflexion moving into plantar flexion at terminal stance. So this is when the heel comes off, and the heel comes off basically, right about here, and then we start moving back down into plantar flexion. So if you can picture that happening in the gait cycle, as soon as the heel comes off the ground, then the ankle starts to move back into plantar flexion, and the initial contact on the other limb is occurring here. Since we're kind of heading back into plantar flexion territory over here, then the soleus, gastroc, tibialis posterior, all of our plantar flexors are still acting. So they're not only, they're eccentrically acting still, and then they're going to start, you see a little bit of a increase in some of this muscle activity as we see a little bit more plantar flexion kind of in the same point of the gait cycle. Now, just a note, especially in, you see the soleus dip down a little bit, same with the gastroc. So basically, at this point, the eccentric activity is decreasing a little bit here for these couple of muscles here and the tibialis posterior. So with regards to these EMG charts, I think they're interesting, and they're helpful to picture the, breaking down the activity of the different muscles and see what's working and what's not. So I like these. I'm not going to really expect you to know that the soleus is working at 80% of its total EMG capabilities at terminal stance. I'm not going to expect you to say that sort of thing. What we would want you to know more of is this type of information, to understand in general which muscles are acting during this terminal stance phase of gait, and to understand that they're still acting essentially eccentrically, that's funny, until, you know, until the toe comes off the ground, basically. So,
And know where the ground reaction forces.
and knowing where the ground reaction forces are in conjunction with all of that. So go ahead, I'm going to speak to Nico.
Okay, go ahead. All right.
Huh?
Is it until the heel comes off the ground or the toe?
For the terminal stance? It's the heel off the ground for the terminal stance until we get into pre-swing, and then it's going to be the toes coming off, getting ready for initial swing.
Right, but the plantar flexors dip when the heel comes off the ground. They start to stop being so eccentric and start to concentrically tract.
Correct. Right. Okay, good. We're good with this one. Can we continue? Go ahead and continue with the other one now. Any questions? Okay. So then we're going to look at the pre-swing, and then we can see here the toe off, what's going on here. It's more of a dorsiflexion getting more into plantar flexion now. So with that being said, right here, we can see what muscles are going to be starting to work more intense at the different levels. And from seeing the AMG, it's looking at the tibialis anterior as having the most work at the pre-swing phase. So we're working eventually from concentric to getting to no activity. So it'll be a lot of concentric of the dorsiflexors. So the tibialis anterior, as well as the extensor hallucis longus and the extensor digitorum longus. There are a little bit of the peroneus brevis, as we can see, and a little bit of the soleus. And then this is going to be at the pre-swing, which is the toe off, which is 50 to 62%. And then this is going to help with propulsion, initiation of the knee flexion for swing. Oops. Okay, and then this is the second arc plantar flexion, and then this is going to decrease, the plantar flexors are going to start to decrease as the pre-swing progresses. So that's going to be the muscle activation, including soleus, the flexor, hallucis, digitorum longus, peroneus brevis, and the peroneus longus.
Question for you guys, what's the first arc of plantar flexion that we spoke about? What phases does the first arc of plantar flexion occur in, or the occurrence, arc or occurrence? Let me give you a hint. It happens early in the gait cycle.
Mid stance?
The mid stance is where we start to see the dorsiflexion, but we start more in a plantar flex position. But before we get to mid stance, the plantar flexion is occurring. Our ankle kind of sort of starts in neutral, and then we immediately go into plantar flexion at loading response. Initial contact sort of 2 is, you know, when the ground reaction force is nice and posterior. So that is where we see our first arc of plantar flexion until the foot is flat, and then the tibia starts to advance forward until we reach dorsiflexion. So in stance phase, we have 2 arcs or occurrences of plantar flexion, one in the beginning and then one in the end at basically the end of terminal stance and pre-swing. And then in between those 2 occurrences of plantar flexion, we have the dorsiflexion that's occurring from basically mid stance to terminal stance. Okay, and then one other thing, I just want to touch lightly on the words hallucis or hallucis. I've heard it pronounced both ways, and then digitorum. So the hallux is the big toe, and digitorum are the second through fifth toes. So when you see flexor hallucis longus, we can break that down and realize that it's the flexor, so it's on the plantar surface or underneath the foot, and it's attaching to the big toe. So that one's primarily flexing the big toe, and then the flexor digitorum longus are flexing the second through fifth toes. So, I mean, there's a ton of muscles in the feet, and while I don't expect you to, you know, be able to know every single little minute detail about all of them, if you see the words hallucis or digitorum or brevis or longus, you should be able to think back, okay, well, hallucis means big toe. So I know that that's going to be flexing the big toe, and then digitorum similarly is flexing the smaller toes, second through fifth. And then brevis, it comes from the root word for brief, so it's a shorter muscle. And then longus, you'll see a ton of times, is just a kind of usually a longer, thinner muscle. So, and then tertius just means third. So peroneus tertius, they couldn't think of a way to describe it other than it's the third peroneal muscle. So just a little something to think about. And that way, when Dr. O asks you what brevis means, you can be like brief, or digitorum, you can be like the little toes, or second through fifth toes. And yeah, we are recording. Yeah. Okay. So this is that was a summary of stance phase.
Okay, so I thought we got into swing.
We should.
We should. Okay. So this is basically just the stance, the summary of the stance phase and what occurs at each phase. So now we're going to get into the 40% of the gait cycle, which is the swing phase. Also really quick with the flexor digitorum as well. Also know it's a dorsiflexor as well as an inverter. It does flex the other toes, the second to the fifth, but it also helps with subtalar inversion. Just on that note. And then initial swing. So most of what's going to occur is going to be, there's no ground reaction forces occurring in the swing phase of gait. So we're going to go more to concentric activity now. Okay. So right here, the concentric, we're going to be looking at more of the dorsiflexors. So we know the tibialis anterior, the extensor hallucis longus, and digitorum longus are working the hardest. It looks more like the tibialis anterior. It looks like the extensor hallucis is working a little bit more so, but not very much difference with the tibialis anterior. Okay. So then initial swing, and now we're starting to be in acceleration mode. This is going to be towards 62 to 75% of your gait cycle. And this is allowing foot clearance to start for limb progression. And this is going to be the second arc of dorsiflexion. Did you review the first arc of dorsiflexion already?
We talked about how it was between, so the first arc of dorsiflexion actually occurs in stance phase, basically from initial stance to mid stance, or yeah, mid stance to terminal stance, excuse me. So we went from plantar flexion at pre-swing to as soon as the toe lifts off the ground, those anterior dorsiflexor muscles start concentrically lifting the forefoot and the toes up to provide this floor clearance. And that's going to continue pretty much until the late swing, once the limb has already cleared. So you're going to see the kind of a similar pattern in both initial swing and mid swing.
So that we know, what muscles do you think are activating during this phase? Okay. Any guesses?
Would it be the extensor digitorum longus, extensor hallucis longus, extensor digitorum brevis, extensor hallucis brevis, and then would it be the anterior tibialis?
Ooh. Ooh,
Very
he got almost,
good.
yeah.
It's tibialis, the 3.
Okay.
Very good. Tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Okay, and what Miss Emily said, it's going still from concentric, and it's going from what looks like about 20 degrees going into neutral. So it's going to be, again, the dorsiflexors again that are going to be more so activating. Okay, mid-swing, it's about 75 to 87% of the gait. And this important function is to have foot clearance. And we're still going to continue through the gait cycle of dorsiflexion concentric control from mid-swing to terminal swing. And then, of course, our dorsiflexors are still assisting in this motion.
Super similar to the last phase. Really, the main difference is mid-swing. The foot of the swing limb is passing, is getting past the stance phase limb. So we're, the tibia is basically vertical, and we're, now getting in front of the limb that's in stance on the contralateral side. That's basically it. Other than that, they're super similar.
They're very similar. Yeah, they're very similar. Actually, throughout the whole phase, except when we get to terminal swing, we're going to start to decelerate a little bit. And that's where we're going to start using more of our isometric control or contract. So it's still the dorsiflexors are still going to be involved, but isometrically. And it'll be, again, the tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Okay, and that's the last cycle of the 87 to 100% of the cycle. And then what we're doing is, I think we had said this earlier, it's preparing for initial contact. So it's going to be the dorsiflexors again with the ankle at neutral. And the eccentric contraction is going to help, and it's going to lower it for initiation for initial contact. And that's pretty much, and then this is the sagittal phase of the swing phase again. And it's a summary of everything that's occurring from pre to terminal swing, or initial, I'm sorry, from initial to terminal swing.
And that's the whole thing.
And then that's pretty much the whole, yeah, exactly. That's the whole summary of what's going on at the sagittal plane of the ankle. Is there any questions so far?
Before you move on,
Yeah.
So looking at the total sagittal plane motion at the foot and ankle, just so that I make sure that you guys understand this chart pretty well, which phase of gait do you see the most ankle dorsiflexion? And I know they're not labeled, so just do your best to identify which one it is.
Mid stance.
It's actually terminal stance, but they are right next to one another. So I don't know how well you can see my cursor. I would rather just have here, laser pointer. So this phase right here is mid stance, where we start to see the dorsiflexion, but the peak of it is going to be in terminal stance right before the heel comes off the ground. So this is at the point where heel off occurs, and then we start to go back into plantar flexion. So going into plantar flexion, which well, it's kind of a nice big exclamation point at what point we have the most plantar flexion. So going from stance to swing, what phases are occurring at the end of stance phase and the initiation of swing phase. So this one is which phase?
Pre-swing into initial swing.
Exactly. So as soon as that toe comes off the ground, the dorsiflexors start concentrically contracting all the way until the end of mid-swing. And then they can kind of take a little break because the foot's already made toe clearance. And then you get a little bit of plantar flexion in preparation for initial contact. But we're still pretty close to neutral. We only have a few degrees of plantar flexion at this little terminal swing phase. And then once we're ready for initial contact, we go right back into plantar flexion. And what's occurring at this initial contact loading response phase? One of the functions of these two phases is what? It's also one of the main functions of gait too.
Shock absorption?
Bingo. So here's where shock absorption is occurring. The foot plantar flexes down, and then the tibia, again, we're just repeating to go over it for repetition's sake, but then we start to go into dorsiflexion as the tibia rotates anteriorly until the heel comes off the ground right here. And then once the heel comes off the ground, we go into rapid plantar flexion. And then again, we start to head into dorsiflexion in order for, this is where we have one of the main functions of swing phase, which is important for patient safety. So what's going on right through here?
Toe clearance?
Bingo. So yeah, we have toe clearance, and then we prepare for stance phase again. So good job, guys. And then this is a complete look at, from initial contact to the end of terminal swing, each muscle. So when does it reach its maximum EMG or maximum? And again, this doesn't say whether, it doesn't specify concentric or eccentric. So it's up to you guys to kind of understand what's going on. I like this one better than I like this one for understanding what's going on at each phase of gait. But this is good to look at which muscles are working. So if you have an issue with your, like I've had a patient that damaged their peroneal nerve and their tibialis anterior was severely, it was deficient. So you can see what phases of gait are going to be primarily impacted by that. So looking at that, I can see that mid stance and terminal stance are not going to be, impaired because it's primarily the plantar flexors, the soleus and the gastroc that are working during those phases. They just so happen to be working eccentrically. So I can then, understand better that the main issue with that patient with that tibialis anterior deficit, they're going to be struggling through these swing phases of gait until, and even including those first two phases of stance phase, which is when the dorsiflexors are eccentrically lowering the foot to the ground. So we'll see difficulty with swing limb clearance, and we'll see difficulty with initial contact and lowering the ground softly. And that was the gait deviation I mentioned called foot slap. So this one is a cool chart. Again, I would rather you guys know more broad strokes on what muscles are working, and are they working concentrically, eccentrically? Are they, where are they in relation to the ground reaction, or what's going on at the joint in relation to the ground reaction force? So we're gonna assemble a little, kind of like a cheat sheet for you. We're gonna draw the ground reaction force at the ankle for each phase, and then, kind of write what's going on. And that way you can refer back to that in the future, because these pictures are good in the stance phase, and I'm not even gonna work my way all the way back because that'll take me too long. But I think it's easier to see it kind of all together in one. And again, we're gonna take some videos of the foot and ankle and the sagittal plane for each of these phases, and I'm gonna cut it. I'm gonna use my fancy iPhone technology to slow it down a little bit, and then we'll add them to this PowerPoint in lieu of the videos that were not playing for us. So does anybody have any questions? We went over the swing phase and the end of stance since the last break. So how are you guys feeling about digesting this information, or is anything kind of unclear? Because we did discuss, muscle activity, joint position, and ground reaction force. So please, if there's anything that's not clear, I'd love to clarify for you.
Can we do a brief overview of ground reaction force? Because I don't really get that at all.
Okay.
Why don't I go back to each one?
Yeah.
Oh wait, you know what? I can do it here. Okay, why don't we do this and then?
Oh, I my writing still stayed
Yep,
up.
it's
I didn't
still
know that was
there.
going to do that.
Do you want to?
Sure. Okay, so the ground reaction force, as Dr. R said, is basically the equal reaction in return, basically being returned from the ground and put onto the patient's, in this case, like against their body, basically. So it's going to change depending on where the body is in relation to the ground. So I wonder if it would be easier to look at it kind of in a whole picture or just the foot and ankle. We'll just cover the foot and ankle. For
Yeah,
right now.
maybe the next session we can, it'll be a better idea to show where exactly it goes.
So remember when I was saying that the passenger unit is going to be, so think about this limb. This limb is extended in front of the patient. They just finished up terminal swing, so their reference limb is anterior to the rest of their body. So as soon as they make heel contact, at that point, the force is going to kind of point up towards their center of mass, essentially. So their center of mass is going to be now posterior to this reference limb since it's extended out in front of them. So picture, let me draw, how did you get my mouse to look so big? I like that. So the center of mass being up there. So center of mass is going to be up here somewhere. And the ground reaction force is going to be from the point of contact, or where the weight is being borne through the limb. In this case, it's the calcaneus because we make heel initial contact, and it's going to go up towards the center of mass, which in this case is going to be a little bit posterior to the point of contact down below. So I don't need this arrow anymore. Let me get rid of that. Oh, okay, well, it doesn't want to cooperate. So what the ground reaction force does is, as the center of mass moves anteriorly, because we're moving in the line of progression, we're moving forward, we're talking about forward walking in this case, as the center of mass moves forward, the point of contact is going to move a little bit forward, but it's going to stay within the limits of the foot during stance phase. So the ground reaction force is going to move and rotate anteriorly like a metronome or a upside down pendulum, and it's going to follow the center of mass as it passes over the stance phase limb. So starting off in initial contact, it's tilted a little bit posteriorly, and it's going to pass just barely posterior to the ankle. So where the ground reaction force is in relation to the joint will determine what action the joint has. So if it's anterior to the joint, it's going to create a dorsiflexion moment. If it's posterior to the joint, it's going to cause a plantar flexion moment, which we'll see primarily in the next phase of gait, because it occupies so much more of the gait cycle. So right here, it's a quick 2%. It's over as soon as it starts, but the ground reaction force is posterior to the ankle all the way through loading response. So looking at this one, my passenger unit is now more just, in alignment with the leg more or less. So the ground reaction force, remember before in my drawing, it was tilted posteriorly. Now it's tilted more anteriorly, because that's what's happening with the center of mass. The center of mass is moving forward. And you see, it hasn't moved positions on the heel. It's still on the heel. because that's where, you know, up until foot flat and it starts to move to the midfoot, that's still where the most of the weight is being borne on the lower extremity. So my ankle joint is still roughly here, and we have a very strong plantar flexion moment as the ground reaction force is posterior to the ankle. And up until the next phase of gait, I'm just going to leave those beautiful drawings up there. We're not even going to erase them. Here's the point where, and you can see basically the pressure is starting to move forward onto the foot because the weight is now passing through the midfoot versus the heel. And then it moves even further forward at the end of mid stance as the foot is, or as the weight is passed onto the metatarsal heads. So the center of mass is still, you know, roughly centered above the body until late mid stance when it starts to move. You know, the limb is starting to get behind the passenger unit. So you see the subtle change in the tilt from early mid stance to late mid stance. Now, what motion at the ankle, which the ankle's right here, what motion at the ankle is occurring during mid stance and terminal stance? Dorsi or plantar flexion?
Dorsiflexion.
So correct. So, and that would coincide with the ground reaction force being anterior to the ankle joint. So think of it like almost an accordion. If you press, you know, if you put weight on a, let me think of a better example. Oh, I'm trying to think of something that would make sense and is practical. Basically, without the eccentric motion of the plantar flexors in this phase, then the ankle would collapse into dorsiflexion because the ground reaction force is going to be bringing the tibia closer to the toes. So picture if we didn't have plantar flexor strength at all, and we have a major force on a hinge, because that's all the ankle joint is a hinge between the foot and the tibia. So it's like closing a book. We're pressing down on the cover of the book and slamming it into the back cover of the book. If we don't have anything keeping that book open, it's going to go ahead and shut. And in this case, shutting the book is like dorsiflexing the ankle. And the where the back cover and the front cover meet is the ankle joint. So the plantar flexors function to slow down the closing of that book, and the ground reaction force is my hand pressing down on that cover, basically, or shutting that cover effectively. And I'll try to think of a better practical example of that. But so in starting at mid stance, the ground reaction force is moving anterior to the ankle joint, and it moves even further anterior at terminal stance, because that's where we see maximum dorsiflexion. So let's move forward. So really this one is it. So here we see maximum dorsiflexion and we start to move into plantar flexion. So that's where the ground reaction force starts to move posterior to the ankle joint once again. And it gets the furthest anterior or posterior to the ankle joint. Well, actually, I don't think it moves anterior again. It stays posterior to the ankle joint until the end of the gait cycle, or anterior, excuse me. So here is a good example of what it looks like when the passenger unit is now full blown as far forward as it can be. So head, arms, and trunk is now, the center of mass is now anterior to the reference limb. You can see where the point of contact and where the weight is being transferred from the ground onto the lower extremity, and then it's going to pass in an anterior direction to the center of mass of the patient, which is located in the pelvis. So here, since we still have the ground reaction force anterior to the ankle joint, it's going to continue to create a dorsiflexion moment up until the foot, this is terminal stance, up until pre-swing when the toes lift off the ground. So as soon as the toes lift off the ground, then the ground reaction forces are no longer acting on that reference limb. Where would the ground reaction, because there's always going to be ground reaction force as long as there's a stance phase occurring. So the only time we don't have ground reaction force is during that float phase that Dr. R was talking about, when both of the limbs are in swing phase, which is only occurring in running, as we know. So this is the, basically this phase and the pre-swing phase are where the ground reaction forces are most anterior. Here, the knee is flexed, so the center of mass is starting to move a little bit posteriorly. So you'll see the angle between, this phase, terminal stance phase and pre-swing phase. They're similar, but we do start to see it move posteriorly a little bit. But the action that would be occurring if all muscle activation was shut off, if we had a switch basically, what would happen is dorsiflexion, because of the relationship, the location of the ankle joint in relation to this ground reaction force. So I think it would be helpful, maybe we take another break because it's about 11 o'clock. If we find a video of the sagittal plane and the ground reaction force as it moves through the different cycles and tie it all together instead of me flipping through a billion slides. And so that you can kind of see that metronome action that I was talking about. And then it'll, and also what's happening at the foot kind of in play. So let's take another quick break. Let's come back. Well, it just turned to 10:59. Let's come back at 10 after, and we'll have a video to show you guys ground reaction force, and hopefully that'll answer some of your questions about what's going on in these different phases.
Thank you. That was helpful.
Okay, good. I'm glad. It's good to go over it all at once too.
Yeah.
All righty.
Take this one. This is a ground reaction force, but it's showing squatting.
Interesting.
I know, like,
I like the sprinting ones or the deceleration ones. I'll probably pull that one up after. Alrighty, guys, let's look. We found there wasn't very many great videos, especially this is what we need because it's showing just the foot and ankle. But we're gonna look at just normal. This would be initial contact and loading response, and then we're also gonna look at some different motions and what the ground reaction forces are doing. So for example, coming off of a box squat and doing shock absorption with the entire lower extremity and decelerating from a sprint, what's happening, which both of those are, you know, they occur in gait 2, but we can see them occurring in a slightly different action. So this, the purpose of this video is to compare these shoes to these shoes, which I read in the description because I was like, why are they completely different? But anyways, so what we're looking at here, we have, we're at basically terminal swing heading into initial contact. So that's why there's no ground reaction forces being seen at this very moment, because we still have, you can still see air and light underneath the heel there. So as soon as the heel is going to strike, then we're going to see the ground reaction force appear. So pa-pa. So you saw kind of a little dive. It started kind of in line with the ankle at initial contact, just slightly posterior. And then as the weight, you can watch his shorts, like the line in his shorts is basically pointing up towards his center of mass, essentially. So watch as his weight transfers onto the foot more, what happens to that red arrow. So it starts to tilt backwards. Now it's even further posterior to the ankle joint, and you can see the malleolus right here. And what's occurring at the ankle joint? We went from plantar flexed to now we're basically in a neutral position of the ankle. So we're at neutral, the ground reaction force is still posterior, and now we're starting to get, the ground reaction force is sliding a little bit more anterior to the ankle as the patient is starting to plantar flex. So then boom, the tibia is rotating over top of the foot, the ground reaction force has now moved anterior to the ankle. And so what do we expect to see happening at the ankle now that that shift has been made from posterior to anterior? What do you guys think? We're at basically mid stance right now. And what occurs during mid and terminal stance? Plantar flexion or dorsiflexion?
Dorsiflexion with the center of mass and weight going anterior.
Correct.
Stance in the terminal.
And we're going to keep seeing as the weight goes from the middle of the foot, where it is right now, to the front of the foot, we're going to see the ground reaction force down here is also going to start to shift anterior. And this arrow is going to start tilting more anterior as well. So let's play it a little bit more forward. There we see the shift. The center of mass is up here. The weight is now being put more towards the metatarsal heads. And we're starting to see more of a gap between the ankle joint and where the ground reaction forces are passing. So as that, the further the ground reaction force line moves from the ankle joint, the more of a dorsiflexion moment we're going to have occurring. And when I say a moment, I mean that that's exactly what the joint wants to do. It's, it would have to work hard to resist that dorsiflexion moment in this phase. So it's going to move even further apart, and then it's going to be, it starts to almost straighten out a little bit because the center of mass is going to be starting to move, forward at a slower rate. And then we're about to experience pre-swing where the toes lift off the ground. So then it's going to decrease and then disappear, because we're now in swing phase on that foot. So let's replay it and watch it one more time. We have a really, does that look exaggerated? It looks very, very dorsiflex, but regardless, we are still in swing phase. There is no ground reaction force working on this reference limb yet. We have initial contact, and the ground reaction force is going to step up and start posterior to the ankle joint, which is creating a plantar flexion moment. So let's bring it back just a hair. So we have a very strong plantar flexion moment as the weight acceptance is occurring. And then at about where the tibia is almost vertical or vertical, the ground reaction force 2 is going straight up through. I would say that's kind of in between the hind foot and the midfoot. It's passing through the ankle, and then it's going to, this is the point basically where the ground reaction force is shifting from posterior to anterior as we go from a plantar flexion moment to a dorsiflexion moment. And then as the patient's weight continues to move anterior with relation to the ankle, then the ground reaction force vector is going to keep moving anteriorly until it decreases and then disappears. So it's kind of interesting that as more weight is being transferred onto, so at this point, the patient's contralateral limb, you can't see it, but it's making initial contact right here and moving into loading response. So the weight that's on the reference limb is being transferred over to the other limb in these next few milliseconds. And while that's happening, you'll see the ground reaction force of this reference limb decreasing, and the arrow is going to shrink down until it disappears, because the arrow on the contralateral limb is starting to grow, which we can't see. So they overlap slightly during the periods of double limb stance. One is shrinking down in pre-swing, and then the other one is rising in initial contact and loading response. So it goes bye-bye, and then, excuse me, and then it disappears entirely. And now, I hope that was a good visual. I would like to then show you the ones that I found pretty interesting. This guy. So it's showing it in both the coronal and sagittal planes, and he's basically jogging towards this mat. he's got the kinematic markers for the anterior tibia, the knee joint, the forefoot, ankle joint, and heel, and the hip. Oh, yeah. Thank you. Ah. So let's see him. And basically, this is going to be showing you can see kind of that accordion that I was talking about, and the moments at the joints, or what the joints are wanting to do. And then we can relate it back to the muscles that are eccentrically working to prevent that motion or moment from occurring. So let's just go ahead and run it. So he's going to make, oh, it's so fast. All right, I'm going to just he does it like 5 times. So I can get it on the next one. So initially, as the ground reaction force is posterior to the ankle joint. It's easier to see on this view here. And that's when his ankle is plantar flexing to get stability, so that we have foot flat. So he's nice and stable. His entire foot's on the ground. And then as he his tibia starts to rotate anteriorly, that ground reaction force is also going to start moving anterior to the ankle. There we go. So now you see what's happening at the ankle is some pretty clear ankle dorsiflexion, and the ground reaction force is anterior to that joint. So as and then as he pushes backwards, which I don't know what that is, why he's doing that. He could just stand up. But anyways, as he's pushing backwards, the ground reaction force decreases because he's putting less pressure on his foot, and he's also plantar flexing. His heel is now only on the ground. So he's now lowering his foot kind of back down into plantar flexion, and the ground reaction force is moving posterior to the ankle once again. So let's watch it in real time. It starts posterior and moves anterior very, very quickly, and then it stays anterior until he's plantar flexing once again. And then this one is what the ground reaction forces look like. Let's just mute it. If a patient is doing basically full body shock absorption. So we typically are shock absorbing during loading response and mid stance, but this is what it would look like. And I just think this is so cool if somebody is jumping off of a platform where the ground reaction forces are. So this shows it really nicely. Ground reaction force in green here is anterior to the ankle, which is causing the dorsiflexion, which we know stabilizes the ankle joint. It's also posterior to the knee and anterior to the hip. So based on what we know about ground reaction forces, what moments do you think are occurring, or moment is occurring at the knee? What do you guys think? Flexion or extension?
Flexion.
Flexion. So that patient's body is coming down into flexion, and his knee is moving a little bit more anteriorly as it flexes forward. And then what do you think is occurring also at the hip? The ground reaction force is anterior to the hip, which causes what moment or action? It's also going to be flexion. So we have dorsiflexion, we have hip flexion. And what's weird is that because ankle dorsiflexion and hip flexion are kind of like two peas in the pod, so when the ground reaction force is anterior, those two behave essentially the same. But then if you try to remember it like anterior is flexion, you're going to get confused, because for the knee, the force vector that causes knee flexion is actually posterior. And it makes sense because of the biomechanics of the joints here. So you can see it pretty clearly, especially with this one. It's nice and slowed down. And then, well, he's also doing a big jump, but then, so right here, his knees are still extended. The weight is borne mostly still on the forefoot, but as the weight comes down, the line is going to shift posterior to the knee, which is causing knee flexion, and we're going to see the hip flexion, ankle dorsiflexion, and hip flexion that we know and love. And then I think he's just gonna, well, they're having their own chit chat in the background, and they're showing some other data off to the left. But pretty much as long, when the knees are extended, the ground reaction force is anterior to the knees. There's, no point really where the ground reaction forces in this example are posterior to the hip or to the ankle. Because, well, except for when because he's plantar flexed when he's in non-weight bearing. So there are no instances in this example where the ground reaction forces are posterior to the ankle, because from the moment he strikes the floor, he's in a neutral to dorsiflexed ankle position for shock absorption, and then he remains in that position until he springs up, and then he's non-weight bearing, so there's no ground reaction forces at play. So I thought this one was cool. I think it's cool how it shows the skeleton at the same time. It's just a good example of another look at ground reaction forces. But we will share the this video, or not this video, the first one we showed. I'm going to post that on your Canvas page for right underneath the ankle kinematics one, PowerPoint. And that way you can take a look at that as you're looking over some of this information to better understand it. We were going to show you this one, but it gets really, really complicated, so we decided not to. So does the video help understand the ground reaction forces a little bit? You can see the line moving from posterior to anterior in relation to the ankle joint, or did that just go right over?
I thought it was helpful.
Okay, good. Thank you, Delaney. So what else did we want to cover today, or is that pretty much?
Pretty much it. And then we were going to talk about the lab.
Okay.
Get in detail with the lab.
So within the visible body coursework, I'm going to invite you to this lab activity. You're going to have the whole entire week to complete it, and it's definitely not all 48 pages here that you see. So we're going to go all the way down to where we see the muscles of the lower leg and the lateral compartment, and I'm going to assign certain pages to you. So for example, it'll be the anterior compartments, lateral compartments, and posterior compartments, and basically it'll start to get you to think about the origin, insertion, action, and innervation for these. We're not going to go into all of these teeny tiny muscles of the feet, like for example the interossei muscles. These muscles, you would not need to know the origins and insertions. You just need to know that they help support the arches of the foot. So it's very basic, so you don't have to worry about a lot of these little tiny muscles. And then, like I was asking you before, things like root words like brevis, longus, digitorum, and hallucis, starting to pull those out of the muscles and will help you understand where they attach and things like that. So I'm going to assign specifics from this lab. I'm not looking at, every single page here. So I'm going to post that assignment this afternoon as well as inviting you to the lab so that you can work on this a little bit. We'll probably break it into chunks. So I won't do the foot yet. We'll just do a couple compartments of the leg, because I don't want to give you too much to worry about when you have other classes to worry about as well. But the good news is that it's going to help you in those other classes, that it's not material or it's not going to be a waste of your time. It's going to help you in the long run. So I'm going to ask questions that are, or incorporate the stuff that's important for us to know for GATE and leave some of the more minute things off of it. So I might just ask you action and origin insertion, and we can leave off innervation, for example, because you're going to get that in anatomy, but for GATE purposes, we really just want to know what it does. So I'm going to post that on your GATE course so that we can, and I'll send you the invitations to your email as well. I'll make sure that Christian, I'll make sure you get it this time, because I felt really bad about that yesterday. He didn't get the original email, but anyways, so we'll set up that assignment. We'll also post the video that showed the ground reaction forces, and then we're going to get to work on making some of our own GATE videos to add to the PowerPoints, because I also feel really bad that none of those videos work for us. So be patient with the videos. We're gonna get them done as soon as we can. We're gonna take all of them today, and then I'm gonna be editing them and posting them we're gonna go ahead and do them for the knee, ankle, foot, and hip PowerPoints, so that you'll have stuff to reference, as well as the GATE cycle. So what I'm thinking we're gonna do is mostly focus on lecture for the next 3 weeks. What we don't want to do is get too far ahead of ourselves and start covering things like pathological gait and gait deviations before we have the basis of what's happening in each phase during, and the timing of it all. So we're just going to focus mainly on lecture, and I will have a plan. I'll combine a couple of the lab scheduled dates so that we can make up these couple of weeks that we're not in person. So I'm not worried about it. I don't want you guys to worry about lab. Just focus on meeting us for lecture, and we'll keep that schedule as usual with the dates and what's being covered on those dates that's in your original syllabus, okay? Does that sound okay to you guys? Okay, all right. Any questions before we get out just a tad bit early?
I have a couple questions.
Sure.
I'll start with my easier one. You said you were going to assign the visible body stuff. Did I miss you saying when it would be due?
It'll be due next week. So don't worry about getting it into me before we meet next Friday. I think you can just download it to your computer and fill it in. It's like a fillable PDF. So you can just email it back to me, or I'll open up a place to submit it on Canvas so that I can see it on there. And you can submit just the pages I ask for, or you can submit the whole thing. I don't really care. I'll be able to find it either way. So I'll give you the exact pages and the exact specifications of what I'm looking for, and you'll have an entire week to turn that in. I would work on it today while we're thinking about it. I'm going to assign it in the next 30 minutes. I'll have those pages and questions posted, and I'll send out the invites right away. So you'll have that. You can work on it today since we're finishing up a little bit early, but that's up to you. You have until next week to do it and submit it.
Okay, thank you.
Yep.
I had one more complicated question. I put it in the chat. It might be easier for you to read it, but I could try to explain it.
Sorry, I didn't even see it in the chat. Where is the chat? Oh, here it is.
Well, we went on break and I didn't get a chance to ask it, so I didn't want to forget.
Okay. All right, the early slides that show the dorsiflexion and plantar flexion degrees are listed as sagittal plane motion. It's my impression that we're viewing this in the sagittal plane, but that's not dorsiflexion and plantar flexion titled sagittal plane motion. It's my impression that we're viewing this from the sagittal plane, but that's not where the motion is occurring. Is that correct? Okay. I believe that with relation to postural sway, I believe that we had sagittal and coronal postural sway, but these motions were being described in the views that they were occurring in and not by the Okay. Yes. So you're going to have to differentiate, and it is pretty confusing to differentiate between the I'm sorry, the planes. I was almost saying phases, but that's incorrect. The planes that the motion is occurring in, and we view them from the perpendicular plane. So plantar flexion and dorsiflexion occur in the sagittal plane, or they're occurring in the sagittal plane, but we have to view them from the side, which is technically the coronal axis or the coronal plane view. So it's basically sagittal plane is, you know, the body's divided into left and right. So if I took a slice down the middle of my body, then the motion occurring within that slice is plantar flexion and dorsiflexion. But if I'm looking at the slice in the sagittal plane, I'm only going to be able to see a little tiny piece of that slice. So which is why we view the sagittal plane from the side, so we can see the slice from a side view. So you can say that we're viewing it in the coronal plane, but it's occurring in the sagittal plane. So when in a practical application and on an exam, basically I have to be extremely clear on whether or not it's occurring in the sagittal plane or being viewed in the coronal plane. So you'll know if you know, you view sagittal plane motion in the coronal plane, and you view coronal plane motion in the sagittal plane. And I will be very clear on, you know, when I'm trying to discuss the planes that things are viewed in or occurring in, what I'm looking for, because I can't leave it up to you guys to figure out what I'm trying to ask. And I try very, very hard based on your feedback of my questions to make it very clear in all questions, in all exams. I love how Delaney, you're like, I can't help you. In the chat anyways. So Adam, does that answer your question? Because yes, as far as postural sway, the coronal plane postural sway is from left to right, and we view that from the front in the sagittal view. And then sagittal plane, well, we talked about postural sway, but just where the center of mass rises and falls is occurring in the sagittal plane, but we view it from the side in a coronal view. And it's not something that will click right away, but as we start to apply observational gait analysis and things like that, once you say it about 100 times, I'll ask you, I'll go, okay, now view it in the coronal plane or view it in the sagittal plane. You know, viewing it in the sagittal plane is looking at it from the coronal view. So it is super confusing until we start to apply it, but trust me, I will, in your gait quizzes and exams, I'll make it very clear what I'm looking for. And if there's any sort of ambiguity, I'll take that into consideration. We'll have a discussion. And if it's unclear, I'm not mean. I'm not gonna, you know, punish you guys for my inability to be clear with those sorts of things. So you don't have to worry about that. Okay.
Thank you.
Yeah, any other questions? I'm gonna, like I said, I'll post a whole bunch of stuff, so you're probably gonna get a billion notifications about Canvas assignments and whatnot. But if you have any questions while you're completing the lab, or if anything's unclear, please email me or Dr. R. Will clarify everything. We're gonna be here all day, so if you're working on it, please don't feel free to reach out, and we'll get back to you right away. And then if you have any questions about ground reaction forces or joint moments or anything that we talked about, I'd rather you guys, you know, shoot us a quick email, and then we can put out a little blast to the class clarifying it if it didn't come out right during the lecture. I'm also going to post the lecture onto Canvas, and that'll show up as like a Zoom recording link that you can either view or download and watch over and over again if you want to hear my voice in your nightmares. Just kidding. Alrighty, so unless there's any other questions, I'm gonna go ahead and get to work. But I'll see you guys in, well, I won't see you guys for a while, but we'll be on Zoom next week at 9. I'm going to send out separate Zoom invitations. Oh, I got another message. Oh, thanks, Tanner. It's like, I don't know if you've ever heard your voice on like a recording, but it's literally the worst thing in the world to hear your own voice back at you. Like, it is the thing of my nightmares, but you know, especially when I've been talking for yeah, especially when you've been talking for an hour or 2 hours, it's tough. So I appreciate that. But I will talk to you guys later, and please email us if you have any questions. Say bye to Dr. R and bye guys. All right, have a good one.
Bye.
I'll share more and end. Did it end it? It didn't even end it.